Hello friends, in this video we present to you a case of a young patient with traumatic cataract and inferior nasal iridodialysis. The anterior capsule has fibrotic changes. There is presence of posterior synechiae at the inferior pupillary area. The yellow markings in the photo shows the area of fibrotic anterior capsule, while the red and white lines denote the iridodialysis and posterior synechiae. The major challenges in this case are the presence of fibrotic anterior capsule and iridodialysis. The patient has opted for an extended depth of focus IOL, so we used a rhexis marker for accurate rhexis centration and size. Most of the steps in the surgery, as incisions and capsule staining, are routine. As the AC is formed with visco, the posterior synechiae is released using the same visco cannula. Now is the time to face the first challenge in this case. The fibrotic anterior capsule at the inferior region extends almost till the anterior capsule periphery. This makes the completion of the rhexis difficult, but in this case we are able to tackle it by carefully going around the fibrotic region. This is a young patient, so we are able to complete the lens aspiration smoothly without use of any phaco energy. After cortex wash, an extended depth of focus IOL is hydroimplanted into the bag. Now that the cataract surgery is completed, we move on to correct the iridodialysis. First, the pupil is constricted using intracameral carbachol. We have chosen to use a sewing machine technique for the iridodialysis repair. Peritomy is done to expose the sclera adjacent to the iridodialysis area. Light cautery is done on the sclera and sclera tunnel is constructed 2 mm away parallel to the limbus. A tenoproline is docked into a 26 gauge needle. The needle used is longer in length than a normal 26 gauge needle. A small tag of suture is left in front of the needle tip. AC is formed with visco and the needle is passed gently through the side port incision. The needle is used to take a bite of the iris root and exits the eye via the scleral tunnel. Forceps must be used to support the sclera at tunnel site for easy exit of the needle. The suture at the needle tip is held with a tying forceps and the needle is retracted into the AC. The needle is used to take another bite of the iris root adjacent to previous one, exiting in a similar manner. The iridodialysis repair can be done taking adjacent bites in this manner, with the needle acting similar to a needle in a sewing machine. This case has a limited dialysis, so 2 bites of the iris is enough to correct the dialysis. The teno suture is tied and the knot is buried in the tunnel. For detailed knowledge on iridodialysis repair by sewing machine technique, we recommend the YouTube video by Dr. K.V. Ravi Kumar. The link is available in the description of the video below. This is the first post-operative day video of this case. In retroillumination, the fundus glow via the iridodialysis area is no longer visible, which was present preoperatively.